Welcome to another short video of this SPOTTERZ series. Now look at this particular abdomen radiograph. This is a very frequently asked spotter in your exam. You can see a prominent bowel loop within it. Which is this bowel loop? Is this a small bowel loop or a large bowel loop? Well, the key to crack this lies in identifying the features of the bowel and the bowel wall folds. You can see some very typical bowel wall folds here. And because this bowel loop is so prominently seen here, is it normal or is it abnormal? What is the likely site of obstruction, if at all, in this particular radiograph? This was a question which was frequently, recently asked in one of your NEET pattern exams. So let us quickly look at how to identify small versus large bowel loops. Now, when a bowel loop gets obstructed, right, it is going to be dilated, right? Just proximal to the site of obstruction, the bowel loop is going to get dilated, right? So when do you say that a small bowel is dilated? So a small bowel is dilated if its diameter is more than 3 centimeters. A large bowel loop is, you say, is dilated if the diameter is more than 5 to 6 centimeters. So remember the rule of 3, 6 and 9. So small bowel loop is dilated when its diameter is more than 3 centimeters. Large bowel loop is dilated when its diameter is more than 6 centimeters, right? So 5 to 6 centimeters. And for the cecum to be dilated, its diameter has to be more than 9 centimeters, because physiologically the cecum may be dilated up to about 8 to 9 centimeters. Okay. Now small bowel loop, just see what is the location of bowel loops. How is the large bowel loop located? Cecum, ascending colon, transverse colon, descending colon, sigmoid colon. So the large bowel loop lies always towards the periphery of the abdomen, whereas the small bowel loops are located centrally. So they are central in location. Because the length of the small bowel is so long, when there is small bowel obstruction, you see multiple dilated loops, whereas in large bowel obstruction, because the overall length of the large bowel is short, you see only few dilated loops. Air fluid levels are seen because of the bowel lumen containing air and fluid. When you do say an erect abdomen radiograph, you can see air fluid levels. So in small bowel obstruction, you again see multiple air fluid levels, but these are short air fluid levels, right? Because the diameter of the small bowel is relatively small. Whereas in large bowel obstruction, you see few air fluid levels, but these are relatively long air fluid levels. Now, always whenever you do an abdomen radiograph, normally there is some amount of air or gas which is seen within the colon, that is the large bowel. That is because it is filled up with fecal content which is interspersed with air, right? So in small bowel obstruction, what is going to happen is that nothing is going to pass distally. Say terminal ileum is obstructed, nothing is going to pass distally into the large bowel. So there will be no air, so none of air or gas you will see in the large bowel in small bowel obstruction, because nothing is going to pass distally. In large bowel obstruction, say for example, there is obstruction at the splenic flexure, everything proximal to the site of obstruction will be dilated, everything distal to it will be collapsed. So yes, you will see air in the part of the large bowel proximal to the site of obstruction, right? The most peculiar way to identify or differentiate between small and large bowel loops is to look at their bowel wall folds, right? If you look at the graphic here, these are the bowel wall folds that you see within small bowel. What are they called as? They are called as, yes, volvulae conniventis, right? Volvulae conniventis. What are these? Look at the graphic there. They are complete transverse mucosal folds extending from one wall of the bowel to the other wall. These are called volvulae conniventis. Whereas in large bowel obstruction, look at the graphic there, these are transverse incomplete folds. Can you see the difference between them now with the magic view graphics here? Yes. So these transverse incomplete folds within the large bowel, they are called as hostrations, right? So these are hostrations. So volvulae conniventis for small bowel loops, right, and hostrations for large bowel loops, right? Now let us look at some specific signs. Now when a bowel loop is obstructed along its length, you can see multiple step like air fluid levels. So this is what is called as the step ladder appearance. So this appearance is what is called as your step ladder appearance along the long axis of a bowel loop. So this is step ladder appearance. Now this air filled content within the lumen of the small bowel, so these are small bowel loops because they are centrally located, can you see? But the content within them is resembling the appearance of fecal matter on CT scan. So this fecal matter like content within the small bowel is abnormal. This is given a name. This is called a small bowel feces sign, right? This content is normally seen within the colon, but when you see this because of the stasis and obstruction within the small bowel lumen, this is called small bowel feces sign. The air specks may get trapped between the volvulae conniventis of a small bowel, right? This is going to give rise to a string of beads appearance, right? And on when we do a CT scan, we look for the site of obstruction where the bowel lumen is extremely narrow. Proximal to it, the bowel lumen is dilated. This is what is called as the transition point. As you can see here, this transition point is telling us or showing us the site of obstruction, and therefore the identification of transition point on CT scan, this is the most reliable criteria, most reliable diagnostic criteria on a CT scan. That is the identification of transition point on CT. Yes. Certain specifics about small bowel obstruction I want you to know. What is gallstone ileus or cholecystoduodenal fistula? So a gallstone passes from the gallbladder or through the biliary tree into the lumen of the bowel, passes along the small bowel lumen and gets impacted at the narrowest point portion of the small bowel. What is that? It is the terminal ileum. It is the terminal ileum. So this is what is gallstone ileus, a gallstone passing into the small bowel lumen, getting impacted at the narrowest part of the small bowel, that is the terminal ileum. This is the most common site of obstruction in gallstone ileus. This condition is associated with a typical Wriggler's triad. What is the Wriggler's triad? Pneumobilia, because when the stone passes from the biliary tree into the bowel, some air passes from the bowel lumen into the biliary tree, that creates pneumobilia. There is impaction of that stone in the terminal ileum most commonly, so therefore small bowel obstruction, and that ectopic gallstone may be seen in the right iliac fossa, that is the site of the terminal ileum, on an X-ray or a CT scan when you do it, right? So this is what is called as Wriggler's triad, which clinches the diagnosis of gallstone ileus. Initial investigation, you may try and do a X-ray. So initial investigation, you may try and do a X-ray which could show the gallstone and features of small bowel obstruction, but the investigation of choice is going to be a CT scan, right? So this is a specific about gallstone ileus. One more important bowel related specific, very commonly asked, favorite of your examiners, is a history of a child coming with vomiting. If the child presents at birth with bilious vomiting and the examiner gives you this history, it means that the bowel has not formed. There is atresia of the bowel at this level, that is usually the distal D2 segment of the duodenum. So you see two bubbles here. The first bubble is the stomach, the second bubble is the proximal duodenum. So a child comes with vomiting, right, bilious vomiting at birth, right, with a double bubble sign. So what is this appearance called as? This is called as your double bubble appearance. What is your diagnosis? Your diagnosis is duodenal atresia, correct? So your diagnosis is duodenal atresia, whereas a child does not present at birth but presents after a few weeks, that is 6 weeks of age, with non-bilious vomiting. That is because now the pyloric, right, muscle has hypertrophied, right, and this pyloric muscle, when it undergoes hypertrophy, whatever content is within the stomach is going to be vomited out. So therefore there is non-bilious vomiting here. So this is your pyloric stenosis. So this is your pyloric stenosis. It is called infantile pyloric stenosis now. Remember, the investigation of choice for pyloric stenosis is now USG, because this pyloric muscle can very well be visualized. The thickness more than 4 millimeters, the length of the canal more than 16 millimeters. These are diagnostic features on USG. So few specifics about intestinal obstruction and bowel related conditions we have discussed here, right? So this was also a recently asked question. Well friends, we are taking small steps every day, right? We are going to make little progress with these sessions every day, and it is going to add up into big results, because you are going to perform very well in your exam when you encounter these similar topic related questions in your exams. So let's keep rocking radiology. All the best.